Wish you all a very good afternoon. 5,000 years ago, people suffered with asthma as well. The only difference is it was not called asthma. It was, I do not know if anybody had even thought about a name for the disease, but there is evidence to suggest that people did suffer from a disease that more or less looked like asthma. This was during the Egyptian period. And because at that point of time, there was no good understanding about what causes diseases, it was believed that asthma is a disease that is caused by demons, spirits, and unhappy gods. So that was the pathophysiology of asthma 5,000 years ago. If that was the understanding of the pathophysiology, then the treatment obviously depended on what was the underlying pathophysiology. So if it was unhappy gods that were causing asthma, if it was demons and spirits that were causing asthma, then the treatment obviously was to keep the god happy, to make the god happy by burning incense. And burning incense has been a tradition in most religious places across the world. Even in India, we burn a lot of incense, especially in front of God, to make the god happy so that he can bless you with health. So it's not only India, but even in many countries in the Southeast Asian region, people continue to burn incense to keep the god happy. So this was the beginning of inhalation therapy for the treatment of diseases. But the inhalation therapy was not directed towards the person who is suffering from it, but it was directed towards the gods, so that they would smell the nice aroma from the incense and they would bless the person with good health. There is a place called Bath in the United Kingdom, which is on the southern part of UK. I have had the opportunity to be in England for a while, and I visited the place called as Hot Water Springs in Bath. The place is called Bath because you have hot water springs where you go and have a bath and you can get relieved or you can get cured from many diseases. And the most popular disease which people used to go to the place called Bath to get relief was for arthritis and for asthma. There is something very special about the hot water springs in Bath. It is believed that the smoke or the fumes that come from the hot water springs has got very healing power, has got healing potential. And people used to have a lot of faith and trust in that, and they used to go to this place to relieve their suffering of arthritis and for asthma. Many people who could not make it to Bath, they did not have the luxury of breathing the fumes of the hot water springs in Bath. So what could be a solution for that? So somebody called Dr. Sales Girons, about 158 years ago, came up with an idea. Because one of his aunts suffered with asthma, she also had a little bit of arthritis, and she couldn't make it to Bath to get the luxury of the healing powers of the fumes. So he invented something called as the first steam nebulizer. And it is very amazing because 158 years ago, somebody had the creativity to think of how you can create steam out of water. And at that time, there was not much of electricity. So you could not build a compressor that you could connect to the electric power supply. So you had to use mechanical energy to produce that compression force. So he used a bicycle pump. So he used a bicycle pump into which water was fed in, that was brought from Bath, and then the fumes or the mist that came out of it was given to his aunt to relieve herself from the asthma that she was suffering from. This is the origin of the first nebulizer that was used for the treatment of asthma about 158 years ago. And since then, people have used a large number of nebulizers to relieve the suffering of people who have lung diseases. Marquette University, 2009, actually patented one new nebulizer because they were taking care of asthmatic people from Africa, where there was very little electric power supply. So there's no point in taking a nebulizer over there that works on electricity How will you run that? You need energy for that. Batteries were also not very easily available. So they have now invented something called as a human-powered nebulizer. This has been patented very recently. You can take it at home, and there are two sources of powering this nebulizer. You can see this person is pedaling, and it is this energy that is used for driving the compressor force, and then you can use the nebulizer for the relief of your respiratory problems. Or you have a hand driven pump. So you keep on driving this generates energy that can drive fine mist production with the help of this compressed tube called as compressed nebulizer. So nebulizers have evolved a lot. Although it was used about 158 years ago, they used a mechanical one. Today still people used to continue to use mechanical ones. So what is a nebulizer? A nebulizer is a device which converts liquid medication into a fine mist that can be inhaled. And it makes sense to do that because we breathe to pull in air, and through the breath we pull in oxygen, which nourishes our blood, and oxygen is extracted through the circulation and then provided to different parts of the body. So why don't we pull in medication right into the lungs, called as targeted drug delivery? So people who suffer with airway diseases or lung diseases, it makes sense to use this form of therapy for the different diseases. It delivers a therapeutic dose of the desired drug as an aerosol in the form of a respirable particles, which you normally use only for about 5 to 10 minutes. So that is what a nebulizer is actually all about. It's an instrument that creates a fine mist of particles which are a sufficient size to enter into the respiratory tract. Should not take more than about 5, 10, 15 minutes, and it should be useful for the treatment of various airway or lung diseases. So why should we prefer a nebulizer route of therapy rather than injectables or other oral medication? So clearly, by using a nebulizer, you're doing targeted drug delivery. If the airways is a problem, then you target the drug to the airways. Why should you swallow the drug, allow it to go into the stomach, get absorbed from the intestine, then go to the liver, then go to the heart, and it's then pumped every single part of your body? So the drug which needs to go to the lungs or to the airways ultimately ends up in going in all the tissues of the body, which is not necessary. So it helps in targeted drug delivery. Because of that, the amount of dose that you use is pretty less as compared to an injectable dose, and therefore you obviously have lesser side effects. Compared to injections, it is non-invasive or painless. So I'm sure many people would not like to use an injection to relieve their symptoms of asthma. Say for example, if they need to use it 3 or 4 times a day. And it is pretty easy to use. You only have to breathe inside when the mist is produced. The advantages of the oral medication are more or less the same, but with the nebulized therapy, obviously you have a faster onset of action because it has already reached the target where it is supposed to act, and therefore it can be used in acute cases of airway diseases as well. So what are some of the important aspects of the nebulization therapy? So this is a photograph of somebody using a nebulizer. So this is the nebulizing device, but the person is using a face mask. When should you use a face mask, and is there any other alternative? So the other alternative is to use a mouthpiece. So you breathe in through the mouth or you breathe in through the nose with the help of this face mask. So which patients should you use a face mask and which patients should you use a mouthpiece? So patients who are too critical, some of them may be unconscious, they're very tired because of the lung disease that they have, such as acute exacerbation of asthma or acute exacerbation of COPD. And even children, they may not necessarily be able to do this. So it is in these patients that you should use a face mask to deliver the nebulized drug. The mouthpiece is essentially used for all other patients. So patients who are comfortable enough to hold the mouthpiece, or if they are receiving anticholinergics. It is important, because if you take the anticholinergic drugs with the face mask, there is a likelihood of the drug entering into the eye. And that could cause problems of acute glaucoma, and that could be a serious problem. So anticholinergic drugs should be very carefully used if you're using it through the nebulizer. Especially, you must not use a face mask. You should use a mouthpiece. And then also those patients who receive steroids, say high doses of steroids. There are so many new steroid formulations that can be delivered by the nebulizer, you must use a mouthpiece. And the reason for that is again the same. Part of the drug can get deposited in the eye, and that can increase the likelihood of developing cataracts. So anticholinergics and corticosteroids, these drugs should be nebulized and should be used with the mouthpiece. So what is involved in what does a nebulizer actually comprise of? So nebulizer comprises of a device where you put in the nebulizing solution. This generates that the nebulizer actually generates particles, a fine mist of particles, and these have to be less than 5 microns in diameter. If they are more than 5 microns in diameter, they are not going to reach the airways. They are going to be filtered off only in the upper part of the respiratory tract. So you have to have a nebulizer that can generate particles of less than 5 microns in diameter. How much solution is ideally suitable for a nebulizer? It should be between 2 to 4 milliliters. It shouldn't be less than 2 milliliters. It shouldn't be more than 4 milliliters. Otherwise, it becomes a problem. If it is more than 4 milliliters, say for example it's 8 milliliters, you may require about 25 minutes of nebulization to take in that drug. So the volume is also very important. What is an ideal nebulizer? An ideal nebulizer is the one that has fast rate of nebulization. So the moment you switch on the machine, the fine mist is already produced. There should be minimum wastage of the drug aerosol. Some of them, they keep on producing too much of aerosol, which the patient cannot inhale. He does inhale it, but a lot of it also goes waste. So it should not produce too much of an aerosol as well. There should be low residual volume and should be made up of well-defined droplet sizes. So this is what an ideal nebulizer should be like. So what are the types of nebulizers that are currently available? Essentially, there are 4 types of nebulizers that are available in the market. The earliest one and the one that is most widely used is a jet nebulizer. Then we have the ultrasonic nebulizer. Then we have the mesh nebulizer, which could either have a static mesh or a vibrating mesh. And then you have the breath actuated or the enhanced nebulizer, the one that I showed you, the cycle one or the hand pump one. So what is a jet nebulizer? A jet nebulizer is the one that uses compressed air technology to generate aerosol. So air is pushed under pressure, and then that air, when it is suddenly released, when it comes in presence with a liquid solution, it creates fine droplets, it creates a fine mist. Probably one of the most widely used nebulizers across the world because it is very cheap. Compared to the other nebulizers, it is relatively cheap. And the other advantage is it can nebulize or it can form a mist of liquid that can, of any type, whether it is a suspension or whether it is a solution. It can almost produce a fine mist of anything, even if it's thin liquid, even if it is thick liquid. It can do that. That is one of the reasons why the jet nebulizers are pretty popular. So here you can see the picture of what a jet nebulizer is. So air under pressure goes in. When it comes in contact with fluid, the pressure creates a big fine mist of tiny particles which are about 5 microns or less in diameter. The problem with the jet nebulizer is because it needs a compressor, so it needs a pump, and a pump essentially is most of the time is pretty heavy. So it's not very easy to carry it. You can carry it, but it is heavy. And the second problem with that is because it has a compressor, there's a machine, there's a motor that keeps on running all the time, it creates noise. So those are the advantages and those are the disadvantages of the jet nebulizer. The ultrasonic nebulizers are a little more evolved than the jet nebulizer. They seem to be a little more superior because they use a very fine technology. They're based on high frequency sound waves which generate the energy to convert the liquid into fine mist. The mist that is produced is a lot more finer than the one that is produced by the jet nebulizer, so the particles can be a little smaller than the ones that are emitted from a jet nebulizer, and therefore the deposition fraction seems to be a little better with the ultrasonic nebulizers. It does not work for suspensions or liquids with high viscosity or those that have a high surface tension. Unlike the jet nebulizer, it can be used to create a nebula of almost anything, whereas an ultrasonic nebulizer can only do it for very fine solutions. It does not contain a compressor, therefore it is less noisy, but it can be bulky. And it is costly because of the technology that it uses of the high frequency sound waves. And these are not cheap to manufacture. Therefore, they are a little on the expensive side. So this is how an ultrasonic nebulizer works. There is a piezoelectric transducer. This electronic oscillator generates a high frequency ultrasonic wave which creates the mechanical vibration that is required to create the fine mist from the water, from the liquid solution that is there inside over here. No compressor, therefore lightweight, and therefore there is very little noise that is generated from the ultrasonic nebulizer. The mesh nebulizers are the ones that are probably the most advanced. So these are the most developed nebulizers. They're based on the mesh technology, been recently introduced. They're more efficient than the ultrasonic nebulizers, less noisy, and they're portable. So they have all the advantages that the jet and the ultrasonic nebulizers do not have. But they're less robust than jet nebulizers, so they can be broken down very easily. They need to be handled very carefully. They can be used to nebulize solutions, but with suspensions there may be a reduction in the performance of aerosol output rate. So that's a problem. It cannot create a mist of any liquid solution, especially those that are in suspension. They may not necessarily be able to do a good job. And these are the different types of mesh nebulizers. So you have the static mesh nebulizer, as you can see here, and then you have the vibrating mesh nebulizer that vibrates and creates the energy that is required. So these membranes, they have about 1,000 to 7,000 laser drilled holes which keep on vibrating, and it is the vibration of these tiny holes, 1,000 and 7,000 of them, that actually creates the energy to create the fine mist or the water droplets. So as I said earlier, it is most efficient, but it is on the expensive side. Now this is something that has evolved over a period of time. This is also a nebulizer called as a slow volume nebulizer or a soft mist inhaler, which is marketed by Boehringer Ingelheim. So this is one of the first products which they used to market quite a few drugs, but tiotropium is the one that is marketed with the soft mist inhaler. So earlier Boehringer used to have the dry powder inhaler, the click inhaler for tiotropium. Now they market the drug through the soft mist inhaler. Now here is a mechanical device which is a spring which you need to coil, and then you suddenly release that. So the coiled spring, when it releases, it generates the energy that is required to produce the fine mist of the drugs. The amount of the dose of tiotropium, which earlier was 18 micrograms, because the nebulizer has got a far better efficiency of drug deposition, the dose of tiotropium is now reduced significantly. I think it's even 1 microgram or 5 micrograms instead of 18 micrograms, which was first launched for the dry powder inhaler device. So nebulizers can be very efficient drug delivery devices. In fact, about 50% of the drugs can get deposited in the airways, as compared to 15 to 20% that is deposited through the pressurized metered dose inhaler. So this is again a nebulizer which is available in a small bottle, and it is not an inhaler, it is a small volume nebulizer. I'm sure people would have heard about this, the electronic cigarette. So here is again, this is a nebulizer in which you have nicotine liquid placed inside, and it creates the energy which nebulizes, creates a nebula of nicotine, and it literally looks like as if you're smoking a cigarette. So this is one of the latest advancements that have taken place, and it's a very interesting technology. They have even shaped the device like a cigarette. So you open the cigarette, you put in a nicotine cartridge, close it, so that one dose is gone into that, and they just have to switch on the machine. There's a battery powered thing which creates a fine nebulized solution of nicotine, and then you literally smoke that as if you're smoking a cigarette. I believe that this technology, once it gets a little more settled, many drugs will be able to be delivered through the cigarettes. And perhaps you may not be aware, but one of the first cigarettes that was used for the treatment of asthma was actually manufactured in India. This was about 2000 years ago, when some of the old Indian herbal medicine specialists, they identified that the leaves of a plant called datura, which contains anticholinergic drugs, if you crush those dried powder leaves, if you burn them and the smoke that comes, if you inhale that, it gives you relief of your cough, your breathlessness and your mucus production. So the Britishers who had come to rule India at that time, they were very surprised that here is a local traditional thing that actually gives relief for people who suffer with asthma. The Indian people had used this in the form of a local cigarette, which we call as a bidi. So the fine, the powder of the datura, the dried powder of the datura was rolled into a leaf, and the leaf was actually smoked as an asthma cigarette. The Britishers, they took this technology back to UK, and instead of putting it in a dried leaf, they put it in a paper. So the paper actually contained the powder of the dried leaves of datura, and the Britishers used to sell them as asthma cigarettes. So asthma cigarettes was a very popular treatment for asthma during about 500 years ago. And then people realized that it actually, the active ingredient is an anticholinergic drug, and then they identified atropine and so on. And that's history. But the reason why I'm telling you that is asthma cigarettes were used about 500 years ago. And here is another cigarette that can potentially be developed as a nebulizer to deliver drugs like even salbutamol. So tomorrow you could take a salbutamol puff with your e-cigarette. And I wouldn't be surprised if that happens in the future. So what are the drugs that can be used by the nebulizer route for the treatment of various diseases? So let us start with the bronchodilators. Essentially, the nebulized drugs were developed for the treatment of asthma or for the treatment of COPD, mainly to bring about bronchodilation so that the symptom relief could be achieved much faster. But then over the years, people have also developed different kinds of solutions to be delivered by the nebulizer for the relief of many disease states. So corticosteroids can be nebulized, mucolytics can be nebulized, and antibiotics can be nebulized. So these are the four main drugs that can be delivered to the airways with the nebulizing technology. Apart from this, there are lots of other drugs that can be delivered for various disease states. There is something called as adrenaline. If somebody suffers with an acute anaphylactic shock, the first thing that you need to give is intramuscular adrenaline, 0.3 milligrams. It's a life-saving drug. I can tell you that. So people who do not have access to adrenaline injections at that point of time, I have seen people die because of an acute anaphylactic reaction to a bee sting or to a wasp sting, and that is at that point of time you realize the value of having an injection of adrenaline. Now, injection adrenaline is not easily available everywhere. So even in India, we don't have injection adrenaline. It's available only in the hospitals where you have to prepare the solution. So somebody has now come up with a bright idea of administering the adrenaline through a nebulizer. Just like you saw the soft mist hailer of Boehringer Ingelheim, so where the tiotropium was delivered with the ultra soft mist. So people are now developing adrenaline solutions to be delivered by the aerosol route. So it's not an inhaler, it's a nebulizer that you can use for the treatment of acute anaphylactic reactions. There's a paper that has just been published this year, and I wouldn't be surprised if it develops into a good drug that can be used for patients across the world. The only problem with that is you use injection adrenaline about 0.3 milligrams intramuscular stat, whereas with the nebulizing solution, you need to use between 4 to 8 milligrams of adrenaline. So it's a high dose that needs to be used with the nebulization route. The other drug that can be used for the treatment with the nebulizer is the treatment of chronic rhinosinusitis. So people who have got big sinus problems, they've got polyps, they've got severe rhinosinusitis. So where the antibiotics do not, the oral antibiotics do not reach the sinuses, and the nasal sprays don't work. So somebody has now developed a nebulizing solution of either antibiotics or corticosteroids that can be only delivered to the nose. So that is something that is just still evolving. So the nebulized drugs can be used for the following conditions. You can use it for the treatment of asthma, for the treatment of COPD. And my talk, I'm going to focus mainly on this. I'm also going to talk a little bit on infections, such as the lung infections. Cystic fibrosis is one common condition where you can use nebulized antibiotics for, because it has been found that injectable antibiotics or oral antibiotics may not necessarily produce the concentration in the airway that is required to get rid of the various bacterial infections. So cystic fibrosis is a condition where you can use nebulized antibiotics. HIV/AIDS is also where you can use nebulized pentamidine, especially if you have all these secondary infections. Bronchiectasis, again with antibiotics. Palliative care, you can relieve pain. You can give them analgesics through the nebulized route. Croup is a disease that is found in children, bronchiolitis or croup, where you can deliver the drug directly with the help of a nebulizer. So these are the different disease states where nebulizers can be used. And this is perhaps what the future is all about, where people are developing gene therapy for the treatment of cystic fibrosis. And the gene is delivered to the lungs with the help of a nebulizer. So this is a study that is currently ongoing in the United Kingdom, which is driven by the Oxford University and the Imperial College, along with the University of Edinburgh. The study started in March 2012, and about £3 million are going to be spent on this clinical trial that will test the efficacy of a nebulizer for gene therapy in patients with cystic fibrosis. So that's the future of how nebulizer therapy will actually progress. I purposely put this slide because many times when we use a nebulizing solution, we tend to add a couple of drugs. So for example, ipratropium with salbutamol or budesonide with salbutamol and so on. But are these drugs compatible with each other? I think it is important to understand that. So here you can see that I made a slide where the green dot, the green tick actually means that yes, they are compatible. So for example, ipratropium is compatible with asthalin, so they can be mixed in the same solution for the nebulizer. Ipratropium is also competent with levolin or levosalbutamol. It can be used with Foratec. It can be used with budesonide. It can be used with fluticasone. It can be used with N-acetylcysteine and so on. But that doesn't mean that all the drugs can be joined together. So for example, over here, the N-acetylcysteine cannot be mixed with other drugs over here, for example. Thank you. So it is important for us to understand and know which drugs can be mixed in a nebulizer and which drugs cannot be mixed in a nebulizer. The second part of my talk is going to be on the role of nebulized corticosteroids in the treatment of asthma. And we all know, I mean, for over the years it has now been well established that asthma is a disease that affects the airways that is associated with a chronic persistent inflammation. This inflammation is fortunately corticosteroid sensitive, and therefore inhaled corticosteroids become the first drug of choice for the treatment of asthma. So they reduce the airway inflammation, they also reduce the edema in the airways, and therefore they are extremely beneficial in bringing up relief for patients of asthma. They're probably the best drugs that can be used to treat asthma. Now, corticosteroids can be given by the systemic route. They can also be given by the inhaled route, especially in acute asthma when we need to have faster onset of action. So systemic route, you can have the oral prednisolone and so on, or you can have the IV hydrocortisone or methylprednisolone. So these are the drugs that can be given systemically. But corticosteroids can also be given by the inhaled route. They can be given with the help of a meter dose inhaler and a spacer. So you can give budesonide, fluticasone, beclomethasone, cyclosonide. They can all be delivered with a pressurized meter dose inhaler and a spacer via the inhaled route. But the recent interest that has developed in inhaled corticosteroids is in nebulized corticosteroids for the treatment of acute asthma, where you can use budesonide as well as fluticasone via the nebulized route to treat acute asthma. And I'm going to show you some of the recent studies that suggest that they are useful over here. So why should you give nebulized corticosteroids, and why not oral corticosteroids? They're so effective. Why would you rather give them by a nebulized route? We know that oral corticosteroids, they require between 6 to 24 hours to improve pulmonary function. So if a patient has come to you with an acute exacerbation for asthma, you give them a prednisolone tablet of 30 milligrams or 40 milligrams, or you give them a hydrocortisone injection, the real effect will start after 6 to 8 hours, or maybe even 10 hours later. Is there something that you can hasten the onset of action of corticosteroids? The dose-response relationships are very difficult to prove, and even single short courses of systemic corticosteroids may cause suppression of the hypothalamus pituitary adrenal axis, and that can be a problem in patients who need to be, who repeatedly have these acute asthma exacerbations. And there is striking inconsistency in the use of systemic corticosteroids to treat acute asthma. So whether you should give 10 milligrams of prednisolone, 20 milligrams, 40 milligrams, 80 milligrams, there is not much consensus on that. So do we have any other options to systemic corticosteroids in treatment of acute severe asthma? Well, obviously you have all these inhaled corticosteroids, and we talked about budesonide, fluticasone given by the pressurized meter dose inhaler, as well as the spacer. But nebulized corticosteroids have attracted a little more attention nowadays, because there are two formulations that are available that have been found to be pretty useful in treating acute asthma exacerbations. So they can be effectively used in chronic severe asthma. They're effective in all patients with acute asthma. And here is the real advantage. The effect starts within 1 to 2 hours to produce therapeutic effects, as compared to the systemic steroids, the oral prednisolone or the injectable hydrocortisone, which takes anything between 6 to 8 hours. This is a little faster than that, 1 to 2 hours. And we'll come to what could be the potential mechanisms of this. So it also produces a little bit of topical effect of vasoconstriction in the airway mucosa, and that helps in relieving the edema, the mucosal edema that patients of acute asthma exacerbations have. It is a potential alternative therefore it is a potential alternative to systemic corticosteroids for treatment of acute severe asthma. In steroid-dependent asthmatics, they can be used to reduce the maintenance dose of oral steroids, and therefore they can have some sort of a useful role over here. So why do nebulized corticosteroids act within 1 to 2 hours? So if you look at the mechanism of how corticosteroids actually work, so a steroid is a very small molecule that enters into the cell. The receptor for a steroid is situated within the cell cytoplasm. So it stimulates the corticosteroid receptor in the cell cytoplasm, and then this complex actually moves into the nucleus, where it binds to the DNA binding elements. And we all know that the DNA is responsible for producing new genes, for producing new proteins. And during an acute asthma attack, the cells are constantly producing pro-inflammatory proteins. And this is because the genes are constantly activated inside the DNA of these cells. So corticosteroids actually go and block the DNA binding element of these pro-inflammatory genes, and therefore the inflammatory mediators that are released, they are blocked because of corticosteroids. So that is how corticosteroids work to reduce the inflammatory response. But more important than that, because this whole process of dampening the DNA binding element takes some time, the more important element, the more important component of how corticosteroids work faster is they help the down-regulated beta-adrenergic receptor to come up again. So when there is inflammation going on in the airway mucosa, the beta-adrenergic receptors that are present on the smooth muscles, they tend to go down, they tend to go inside the cell. And if you keep on giving them beta agonists like salbutamol or isoprenaline, the beta-adrenergic receptors, they undergo receptor desensitization. And most of the receptors go and sit inside the cell. And therefore, no matter how much salbutamol you give at that point of time, it doesn't work as well, because the receptors are not sitting on the membrane of the cell, of the cells. So what corticosteroids actually do is, the moment they come inside the cell, apart from the DNA blocking activity that it has, it forces the beta-adrenergic receptors that have down-regulated to go and again express themselves on the cell membrane. And this has been shown. This doesn't take much time. This can take place within an hour or so. So by giving corticosteroids, your beta-adrenergic receptors are now back on the cell membrane, and now you give them salbutamol, the bronchodilators, they work a lot more effectively. So corticosteroids actually help in increasing the bronchodilator activity of beta-adrenergic activities, or beta-adrenergic drugs. And this is perhaps one of the reasons of how quick onset of action with nebulized corticosteroids actually works. So one of the drugs that is being widely used in the treatment of acute asthma exacerbation is fluticasone. The advantage of fluticasone is that it has got very little oral bioavailability. So you cannot swallow it, and if you swallow it, it's gone, nothing will work. It has got good binding receptor affinity as compared to the other corticosteroid molecules, and it is highly lipophilic, and therefore it stays in the airway mucosa for a relatively longer period of time as compared to the other corticosteroid molecules. And therefore fluticasone seems to have a chemical advantage of why it is probably a better drug in the acute management of asthma. So just a couple of slides. These are some of the old data where they compared the efficacy of nebulized fluticasone with oral prednisolone in children with an acute exacerbation of asthma. So this is a paper that was published about 12, 13 years ago. A randomized, double-blind, placebo-controlled, parallel group study, a pretty large sample size, children between the ages of 14 to 16 years who presented to the hospital with an acute exacerbation of asthma. And then they were randomly allocated to receive either nebulized fluticasone in the dose of 1 milligram twice a day or oral prednisolone. And they were able to show that those children who received nebulized fluticasone, they seem to be showing better improvements in peak expiratory flow rates over a period of 7 days as compared to what was produced by the prednisolone. So there seems to be some better, superior therapeutic efficacy of nebulized fluticasone over oral prednisolone in children who suffer with acute asthma exacerbations. And as you can see here, day 1, day 7, improvement in lung function was, fluticasone was slightly better, although this was not significant, but at least it was as good as oral prednisolone. And we all know that oral prednisolone will have more side effects than nebulized fluticasone. So the result obviously was suggesting that nebulized fluticasone is at least as effective as oral prednisolone in the treatment of acute asthma exacerbations, especially in children. So there is some evidence that has been generated that nebulized fluticasone is as good, or if not better, than oral prednisolone. The second study was published about 7-8 years ago, nebulized fluticasone propionate versus budesonide as adjunctive treatment in children with asthma exacerbation. So this is again a large multi-center, randomized, single-blind, parallel group design. Not as many children as compared to the previous study, but the study design was such that they randomly allocated to receive either nebulized fluticasone in a dose of 250 micrograms or nebulized budesonide in a dose of 500 micrograms twice daily for 10 days along with salbutamol. So both the groups of children received salbutamol. What is the bottom line? The bottom line is you can see that fluticasone produced better bronchodilator effects than budesonide. So as you can see here, this is better than this and this is better than this morning as well as evening. And there was no evidence of hypothalamo-pituitary adrenal axis suppression. So this is one of the first studies that actually showed that fluticasone may probably be better than budesonide in the treatment of acute asthma exacerbations in children. And they saw that it has the same effect as the double dose of nebulized budesonide when either drug is added to a bronchodilator therapy. This is the third study, which is again an old study, that examined the oral steroid sparing effect of 2 doses of nebulized fluticasone propionate and placebo in patients with severe chronic asthma. Now this is not acute asthma exacerbation. This is chronic asthma where you need to use a nebulizer on a regular basis. So obviously the study was for a period of 12 weeks, randomized, double-blind, a pretty large number of patients. And here they compared oral steroid-dependent asthmatics who required at least 5 milligrams per day of prednisolone, but not more than 30. And they were randomized to receive one of these 2 medications: nebulized fluticasone 2 milligrams twice a day versus 0.5 milligram twice a day, along with placebo. And as you can see, a nice dose-response effect. So patients who were given fluticasone 4 milligrams twice a day, at the end of 12 weeks, they produced much better improvement in lung function as compared to those who received the other dose. So here is again some evidence to suggest that nebulized fluticasone works better. And then if you look at the peak flow, it was not the 4 milligram dose that produced a better result, but it was the 1 milligram dose that produced the better result. So the authors concluded that fluticasone nebulizer suspension at a daily dose of between 1 to 4 milligrams are as safe and effective means of reducing the oral corticosteroid requirement of patients who are on chronic oral therapy with oral steroids. So what is so special about fluticasone as a nebulizing drug for the treatment of asthma? The first and only nebulized corticosteroid approved for acute exacerbations of asthma in children between the ages of 4 to 16 years. Faster clinical improvement, the option for the treatment of acute attacks, and it reduces dependence on oral steroids. So those patients who need to be put on oral prednisolone, there you can use this to reduce the dose of oral prednisolone. And these are the doses that are widely recommended for fluticasone in the treatment of asthma. The third part of my presentation, I'm going to highlight some of the other uses of nebulized therapy for other conditions. So I'm going to be speaking on nebulized antibiotics with a little focus on tobramycin, because this is an important antibiotic that can be used for the treatment, especially of cystic fibrosis. So cystic fibrosis is a very common disease that we encounter in clinical practice, and one of the problems of cystic fibrosis is these patients develop bronchiectasis, and it is largely because of the Pseudomonas infection. So Pseudomonas is the bacteria that grows the most inside the airways of patients who have cystic fibrosis. So obviously you need to have a good antibiotic that can get rid of the Pseudomonas infection. The problem with the antibiotic is they produce a lot of mucus, and the infection is within the mucus over here, and this prevents the systemic antibiotics from entering into the airways. So there is poor penetration of both intravenous as well as oral antibiotics into the endobronchial region where the infection is going on. And at the same time, there are sputum glycoproteins that inhibit the antibiotics to reach the target. And therefore, you need very high local concentrations of antibiotics to get rid of the Pseudomonas. So if you look at some of the earlier studies of 2001, a paper published in Chest, that if you use tobramycin at 10 times MIC, you can reduce the amount of Pseudomonas in the airways, and if you use 25 times MIC, you can significantly bring it down. So there is a nice dose response effect to suggest that nebulized tobramycin can actually get rid of the Pseudomonas in the airways. And what is the advantage of an aerosolized antibiotic in these patients? So obviously you're delivering the antibiotic straight to the target where the bacteria are growing, and therefore you can achieve high concentrations at the local sites as compared to the IV route or the oral route, where you cannot achieve high concentrations. And these high concentrations will then be responsible for effective killing, low systemic absorption, and low incidence of adverse side effects. And let me show you this slide that supports that. So when you give IV tobramycin, the circulating tobramycin in the blood is pretty high, which is expected because you're giving it as an IV dose. When you give an aerosolized tobramycin, the amount of circulating tobramycin is much less. And on the other hand, when you give IV tobramycin, although the concentrations are very good in the plasma, they're very poor in the sputum samples of patients with cystic fibrosis. Whereas if you give an aerosol tobramycin, the local levels of tobramycin are extremely high as compared to what you can achieve with IV tobramycin. This is the advantage of using nebulized antibiotics in patients with cystic fibrosis. So what is tobramycin? It is an aminoglycoside antibiotic that works on the principle of protein synthesis inhibition of the bacteria. Drug of choice, one of the drugs of choice for Pseudomonas aeruginosa. It is about 4 to 8 times more potent than gentamicin and amikacin to get rid of the Pseudomonas infection. And there is some evidence that it also has some anti-inflammatory effect. There are studies that have shown that by giving nebulized tobramycin, you can not only improve lung function, but you can also kill all the pseudomonal bacterial load that is growing on inside the airways. This is a significant advantage. No nephrotoxicity or ototoxicity when administered for 2 years in patients with cystic fibrosis. So this is important because IV antibiotics can affect the kidneys and the ear. The side effects are very high with IV antibiotics and almost negligible with the nebulized form of tobramycin. Patients have been shown to require fewer hospitalizations and less IV Pseudomonas therapy. So here is an antibiotic that has got a distinct advantage for patients of cystic fibrosis to get rid of the Pseudomonas infection. And this is the dose that is recommended, 300 milligrams Respule twice a day. It does not need to be adjusted by weight, and you need to give about 28 days of tobramycin followed by 28 days of rest. Again, 28 days of tobramycin followed by 28 days of rest. The recommended order is first you give a bronchodilator, followed by chest physiotherapy, and then you give the inhaled medications, and finally the tobramycin. So this is important, because if you want to deliver tobramycin by the nebulized route, you need to do your pre-work first before you nebulize them with tobramycin. It can be given in the sitting position, standing upright position, and so on. So there's no specific method for doing that. The other indications for tobramycin are in patients who have repeated infections due to underlying bronchiectasis, or those who have ventilator-associated pneumonias. And they're extremely useful, just like how they're useful in patients with cystic fibrosis. So this is a study that compared the efficacy of tobramycin in patients with bronchiectasis. And as you can see here, the red bar is those who received tobramycin, and the yellow bar are those who received placebo. So there seems to be a significant beneficial effect in patients who received nebulized tobramycin for the treatment of their Pseudomonas infection. And what was found was that it eradicated about 92% of the bacteria in patients of bronchiectasis. So again, another study that was published a few years ago, open label study in patients with severe bronchiectasis. So tobramycin was given in a dose of 300 milligram twice a day for 12 weeks. And you can see the beneficial effect with tobramycin in terms of symptom reduction, activity improvement, impacts on total life, and so on. The quality of life was much, much better with nebulized tobramycin. And they were able to eradicate Pseudomonas in 26% of the patients, and also reduce the sputum volume in 60% of the patients by about 2 to 4 weeks. So that's a distinct advantage of nebulized tobramycin. The last part of the talk is on use of tobramycin in ventilator-associated pneumonias. And I'm going to quickly rush through this, because ventilator-associated pneumonia is a very serious condition, not very easy to treat, and many patients die because of the underlying infection that they have. So somebody actually did a drug deposition study in patients who are on ventilators to see, is there any drug that actually reaches the lungs if it is given by the nebulized route. And yes, I mean, there is some deposition of the drug that does occur even in mechanically ventilated patients. So you can that makes sense to give them antibiotics by the aerosol route. And this is just one study that I would like to cite, where they compared IV versus aerosolized tobramycin in patients who had ventilator-associated pneumonia. And compared to the IV drug, the aerosolized tobramycin was far better in terms of the symptom scores, as well as the serum creatinine levels were far lower in those who received the aerosol tobramycin as compared to those who received the IV tobramycin. And the success rate was almost 100% on those who received the aerosol tobramycin, and they required less number of ventilator days for this. So this was just a summary of the progressing world of nebulization therapy. So you can use it for bronchodilator effects, which I did not cover. You can use it for anti-inflammatory effects. You can use it for antibiotic effects. You can use it for mucolytic effects, and so on. So I think the field of nebulizer therapy is growing, and I would not be surprised if there are more and more drugs that will be developed through the nebulizer route for the treatment of various lung disorders. Thank you very much.
Okay, we'll open the floor for questions.
Yes, please.
Thank you for this very interesting talk. Can we extrapolate to any other antibiotics for nebulization? Any other?
There are lots of antibiotics that can be nebulized. So you can even nebulize gentamicin, you can nebulize amikacin, you can nebulize colistin. But but you need to do it properly. There needs to be some research, basic research that needs to be done to find out whether it is safe and whether the particle size that is generated is sufficient to reach into the small airways. Many of them are thick suspension solutions, and therefore the nebulizers cannot produce a fine mist. So it is only some of the antibiotics that can be potentially delivered by the nebulizer route. And the most experience is with tobramycin, with colistin. These are the most widely used antibiotics, especially because of the need for treating patients with cystic fibrosis with local delivery of antibiotic drugs. Please. Yes, ma'am. Sir.
In which nebulized antibiotic do you find bronchoconstriction problems?
Oh, quite a few of them. I mean, that's one of the reasons why you have to be very careful with some of the antibiotics. N-acetylcysteine is a very good drug, which is a mucolytic as well as a antioxidant drug that I particularly like a lot. But the moment you give N-acetylcysteine by the nebulized route, it causes a little bit of bronchospasm. And that's a problem with some of these drugs. So some of the antibiotics would cause bronchospasm, and that may obviate the use of them through the nebulized route.
Is it the vehicle which is the problem, or the molecule itself?
I think it's both. So sometimes it's the vehicle that is the problem, sometimes it's the chemical nature of the antibiotic that could be responsible for causing the bronchospasm.
Please. Thank you. Can I know...
Thank you for your very, very interesting presentation. I am surprised you talked about inhaled corticosteroids for acute asthma. I like very much, but in the global initiative for asthma guidelines, they didn't really...
Not yet.
They didn't really put it clearly, you know. So
I think there's a reason for that.
Know, huh?
I think there's a reason for that. The evidence that has been generated on inhaled drugs or oral drugs, oral prednisolone, for example, for the treatment of acute asthma exacerbation, there are hundreds of papers. But the number of papers that support the use of nebulized corticosteroids are about 5, 6, 7, at the most 10. So I think that we need to build up on the evidence a little more stronger. And second is, I believe that there's a fear that many people may misuse nebulized corticosteroids for the acute asthma exacerbations, and therefore it has probably not gone into the guidelines yet.
Thank you. What's the effect of using antibiotic through nebulization on development of resistance?
Very good question. Very good question. Well, fortunately, there is not a lot of fear about developing antibiotic resistance because of nebulized drugs. There has been a lot of study done on this, especially in cystic fibrosis. In patients who use nebulized tobramycin, do these patients end up developing drug-resistant tobramycin? The answer is no. I do not know for what reason, but there seem to be less or insignificant amounts of drug resistance that develops with the nebulized antibiotics. But that's a very good question. Yes, please.
Thank you, Doctor. Other drugs can be used for treatment of asthma as a nebulizer, like the chromoline and anti-leukotriene drugs.
There is a new anti-leukotriene drug that is being developed to be given by the inhaled route, and I believe it is being developed by MSD, Merck Sharp and Dohme, but it is not yet available in the market. It's still under clinical trial stage. So tomorrow you would probably see nebulized anti-leukotrienes that are available for treatment of acute asthma exacerbations.
Sorry, Dr. Salvi. Many studies have shown that really there is no difference. If you take the MDI or the DPI, if you take them properly, there is no difference between them and the nebulizer. So why shall we, bother with the nebulizer and take time with it? And we have many problems with it. You see, if you put a higher volume, then the time will be longer and the compliance will be less. If you put small volumes, then the problem will be, the medication will be mostly in the dead space of the apparatus. So if the patient can take properly the inhalers, why should we put the nebulizer?
If the patient can use an MDI with a spacer easily, or a DPI easily during an asthma exacerbation, that is what he should use, not a nebulized drug. And in fact, 90% of the patients or 80% of the patients would essentially require only an inhaled drug with a spacer. Nebulized drugs would essentially be required for patients who have got an acute attack where they're even unable to breathe in properly. So that would be a small proportion of patients.
Even in emergency room, some advocate the use of MDIs rather than a nebulizer. Yeah, it is as effective.
Yes, I mean, I am a strong proponent of MDI with a spacer, even in an acute asthma exacerbation. You should reserve the nebulizers for seriously ill patients who cannot breathe properly. Many patients, you may give them an MDI with a spacer, but they just can't take the drug inside.
Okay, thank you very much.
Thank you.
Very much.
Thank you.